So today I'll be presenting slides on bronchial asthma, a breathing remedy journey. Myself, Dr. Abhishek Paserkar, PG third year. So what are the objectives of today's session? Is at the end of the session we'll be able to list the therapeutic drugs for management of bronchial asthma, status of the already existing drugs, new targets, and some GINA 2024 guidelines. What is bronchial asthma? Bronchial asthma is defined as a reversible chronic inflammatory airway disease which is characterized by bronchial hypersecretion, hyperresponsiveness of the airway to various stimuli leading to widespread bronchoconstriction, airway flow limitation, inflammation of the bronchi causing symptoms such as wheeze, chest tightness, and dyspnea. What are the triggering factors? There are different types of triggering factors such as pollens, bugs in the home. Then we have chemical fumes, cold air, fungal spores, dust, smoke, strong odors, pollution, anger, stress, pets, exercise. So this is the pathophysiological part, as this is the normal and this is the disease part. Okay. So in the disease part, we can see invagination of airway by smooth muscle contraction, then airway edema, cellular infiltration as it is a inflammatory disease. So cellular infiltration occurs, neuronal proliferation, vascular proliferation, epithelial denudation and shedding, mucus production. There are two types of inflammation occurs in asthma on the basis of their etiology, that is intrinsic, and this is the extrinsic involvement. So intrinsic leads to antigen production which activates TSLP, and in this IL-6 and CXCL8. In the further slides we'll study that these inflammatory mediators are responsible for new targets, treatment, or new treatment available for us. Here are a few examples of the drugs. For an example, omalizumab is an anti-IgE. Then we have mepolizumab, which is anti-IL-5, benralizumab that acts on anti-IL-5 receptor, dupilumab, which acts on anti-IL-4 and IL-13 receptor, and tezepelumab, which is anti-TSLP. We'll discuss it further. What are the goals of management of asthma? First is to control the symptoms, then prevent exacerbation, maintain normal PFT, avoid adverse effects, and prevent asthma mortality. What are the short-term approach? Short-term approach is to relieve the symptoms, and long-term approach is to control the symptoms and prevent future attacks. As I drug use in bronchial asthma. So I have made a mnemonic where we can easily revise drugs for bronchial asthma. So just imagine this as just write bronchial. So BRO is for bronchodilators. Imagine N as M, which is mast cell stabilizer. C is corticosteroid. HI is nothing. A is anti-IgE. L is leukotriene antagonist. Okay, these are the drugs. So in bronchodilators there are beta sympathomimetics, that is beta 2 sympathomimetics, salbutamol, tibutol, albuterol, almetol. Methyl synthesis में we have theophylline, aminophylline, choline, theophylline, hydroxyethyl theophylline, doxophylline. Anticholinergic में भी apratropine, bromine, and tiotropium. In mast cell stabilizer we have sodium chromogylate, ketotifen. Then in corticosteroid we have systemic, and inhalational systemic we have hydrocortisone, prednisolone, other glucocorticoid. Inhalational we have beclomethasone, dipropionate, budesonide, fluticasone, propionate, flunisolide, and cyclazonide. Then we have A is anti-IgE, that is omalizumab. L is for leukotriene antagonist, which is montelukast and zafirlukast. These are the new drugs or biologics that are available for treatment of asthma, such as NDIG is well known, omalizumab, IL-5 mepolizumab, reslizumab, IL-5 alpha benralizumab, IL-4 alpha dupilumab, TSLP, which is thymic stromal lymphopoietin inhibitor, tezepelumab, and dual IL-4 and IL-13 antagonist, which is pitrakinra. New drugs or repurposed drugs that are available for treatment of bronchial asthma is non-selective PDE4 inhibitor, that is roflumilast, PD3 or 4 inhibitor, that is ensifentrine, magnesium sulfate, potassium channel opener such as levochromacalin or chromacalin, beta taste receptor agonist. Now, role of beta 2 agonist in drugs in asthma. They are usually the reliever or rescue medications. Salbutamol and terbutaline are commonly used for foster of an onset. They use in acute attack. Terbutaline is safe in pregnancy. Half-life is 2 to 4 hours. While long-acting except formoterol, all drugs have slow onset of action. Duration is more than 12 hours. They inhibit the late phase of allergen-induced asthma. So formoterol and salmeterol are commonly used for prophylaxis for asthma, nocturnal-induced asthma, exercise-induced asthma. Should not be used alone. Very or ultra long acting, more than 12 hours or duration of action, is indacaterol, olodaterol, vilanterol. Then future of beta 2 agonists is still a standard treatment of asthma. Role of muscarinic antagonist. Muscarinic antagonists are SAMAs and LAMAs. SAMAs are short acting muscarinic antagonists. We have ipratropium and oxytropium, and long acting we have tiotropium, acetylidinium, glycopyridinium, umoclidinium. Muscarinic antagonists causes relaxation of bronchial smooth muscle. They are less effective as bronchodilators as compared to betas and pathomimetics. Onset is delayed. These are used as an additional drug only with beta 2. Ipratropium bromide have specific action on bronchial smooth muscle. Onset is slow. Duration of action is 6 to 8 hours. Used along with beta 2 agonists. They can be used in both MDIs and nebulizers. Tiotropium, this is long acting muscarinic antagonists which are bronchoselective and long acting. Reduces exacerbation of acute attack. Studies have provided improved lung function. Few areas that are reported, that is better taste and relation precipitation of glaucoma and elderly people. Actually, tiotropium causes mydriasis, which is responsible for this area, that is glaucoma. MABA therapy. MABA is nothing but combination of LABA and LAMA in a single molecule. It is a bifunctional or dual pharmacophore agents. These are the new novel approach. Now, role of corticosteroid in bronchial asthma. We have structural glucocorticoids causes structural cell changes and immune cell changes. In structural cells changes, we have smooth muscle cells, which increases beta 2 expression and decreases mediator expression. That decreases respiratory endothelial cell, goblet cell mediators, mucus secretion, tight junction remodeling. They also decreases microvascular leak and decreases angiogenesis. They also decrease immune cells such as mast cell, eosinophil, dendritic cells, lymphocytes, and macrophages. Corticosteroid in inflammation. Steroid potently inhibit the formation of multiple inflammatory factors. Release from cytokines. This Th2 is the parent molecule, which is the starting point of inflammatory cascade. So corticosteroid generally inhibit this Th2 cells. Corticosteroid induces eosinophil apoptosis as well as used in eosinophilic asthma. Corticosteroid inhibit expression of multiple inflammatory genes. Corticosteroid prevent and reverses the increase in vascular permeability due to inflammatory mediators. Status of corticosteroid, they are still in use. In case of therapy with persistent asthma, they are also used in mild, moderate, and severe asthma. Now, interaction with beta 2 adrenergic drugs. So, steroid potentiates the effects of beta 2 agonists on bronchial smooth muscle and prevent reverse beta receptor desensitization in airway. Basically, they potentiates the effects of SABA or beta 2 agonists. That's why they are used. They are used in combination. Future development, new corticosteroids with fewer systemic side effects is desirable. Now triple therapy. Triple therapy, we have LABA, LAMA and ICS. Used in severe asthma, single inhaler as available, such as endacatrol, glycopyrronium, omeprazole. The role of methylxanthines in asthma. Theophylline. Theophylline exhibit bronchodilatory and anti-inflammatory and immunomodulatory effects. These are not used nowadays because availability of more selective drugs, having more selective action, still used now in some developed countries because of low cost. Doxycycline. This is the novel xanthine bronchodilator, inhibition of PD4, which is a safer drug. Mast cell stabilizer, we have nidoquramil and cromolyn sodium. They are used in bronchial asthma prophylaxis, allergic rhinitis, and allergic conjunctivitis. This is the leukotriene pathway inhibitor. So in leukotriene pathway, there is membrane phospholipid, which in presence of PLA2, that is phospholipase A2, leads to production of arachidonic acid, and then in presence of COX, prostanoid, in presence of LOX, 5-HPTE, PETE leads to L4, LTA4, B4, D4C, E4. So, few drugs that act along the way is corticosteroid inhibit PLA2, xylutine inhibit LOX enzyme, while montelukast and sapablukast inhibit this receptor antagonist. Okay. Then we have leukotriene inhibitor, xylutine, which is inhibits synthesis of 5-LOX products like A4, B4, C4, D4, E4. It has short duration of action. It is a hepatotoxic drug. Then we have leukotriene receptor antagonists such as Monte, Zafir, Pranlukast. They inhibit exercise-induced asthma and aspirin-induced bronchospasm. They relieve the bronchospasm and mucosal edema. ADR is vasculitis and eosinophilia. Zafir Lucast interact with warfarin and leads to its precipitation, thus toxicity of warfarin toxicity. Magnesium sulfate, which is a repurposed drug, it is used as a bronchodilator. It acts by reducing cytosolic calcium concentration in bronchial smooth muscle cell, which leads to bronchodilation. Few ADR that are reported as flushing and nausea. It is used as an additional drug to SABA and severe asthma, given IV and nebulization. Magnesium sulfate is also used in preeclampsia. It is used in bandages. Mag-sulf. Then biologic in asthma. Omalizumab, as you all know, is a monoclonal antibody that acts against IgE. It's given by SCC. Patients who are not controlled by any corticosteroid. So it is your high cost is the main reason why these drugs are not used on regular basis. Few areas reported by it are redness, stinging sensation, and anaphylaxis. As it is in monoclonal antibody, anaphylaxis is the commonest ADR. Then omalizumab. Omalizumab binds to free IgE, decreases cell-bound IgE. It also decreases expression of high-affinity receptors such as Fc receptor present on mast cell. It also decreases mediator release, inflammatory mediator release. It also decreases allergic inflammation and thus preventing exacerbation and reduced symptoms. That is allergic inflammation. Now we have benralizumab. Benralizumab is an anti-IgE1. It is the add-on for severe eosinophilic asthma. It binds to IL-5 receptor, leads to apoptosis of cell through antibody-dependent cell-mediated toxicity. Few side effects such as headache, pharyngitis, fever, hypersensitivity reactions are common in benralizumab. What benralizumab does, that it binds with the Fc receptors of natural killer cells and with IL-5 receptor present on eosinophil, thus releasing granzyme and perforins, which leads to death and apoptosis of eosinophil. Then we have mepolizumab. Mepolizumab is a humanized IgE1 antibody which acts against interleukin 5. It is used as a maintenance therapy for severe asthma patients with eosinophilic type. Then it is used as in hypersensitive hypereosinophilic syndrome. Few areas that are reported are upper abdominal pain, headache, injection site reaction, fatigue, UTIs. So how does it act? So racemozumab and mepolizumab basically get inhibits IL-5 receptor and thus decreases its transduction. No signaling, no further signaling. These are the few drugs that are available, such as we have IL-5 mepolizumab, racilizumab, given SCIV, IL-5 alpha receptor benralizumab subcutaneous, 4 alpha dupilumab pitakinra subcutaneous, 13 lebrikizumab tralokinumab, NDIG is quilizumab, ligelizumab, omalizumab. Now tezepelumab, as we have discussed in the previous slide, that TSLP is the parent inflammatory mediator which is responsible for its inflammatory for the start of inflammatory cascade. It reduces chronic inflammation. It is used in treatment of severe asthma as an maintenance therapy. Areas are injection site pain and redness swelling. This is the sum up of all the three. As you can notice, this is the TSLP. In allergic asthma, dendritic cell, mast cell, TH helper, B cells, and basophil cells are involved. In eosinophilic, interleukin C2, IL-5, and eosinophils are the causative agent for asthma. And dendritic cell activation leads to TH0 and TH17, neutrophil activation, and fibroblast mast cell TSLP, thus degranulation and polygranulocytic. Now we have dupilumab. Dupilumab is a molecular antibody which acts in IL-4 and 13 subcutaneously given. Eosinophilic phenotype of corticosteroid dependent asthma. Pitakinra is a IL-4 alpha receptor antagonist and blocks the interleukin 4 alpha receptor, reduces the lead response, and effective in high eosinophilic count in patients with high eosinophilic count. Lebrikizumab or tralokinumab, it is anti-IL-13. It is used in moderate to severe asthma. It improves FEV1, that is forced expiratory volume 1. Now we have anti-IL-17, secukinumab and brodalumab, severe asthma. It is under phase 2 trial. It causes inhibition of neutrophilic inflammation, airway remodeling. So this is the sum up of all the drugs that are available, such as tezepelumab, dopilumab, dupilumab, mepolizumab, benralizumab, secukinumab, omalizumab. And now we have phosphodiesterase 4 inhibitor. These are non-selective PDE4 inhibitor. Drugs such as roflumilast, cilomilast. They reduces release of cytokines, decreases migration of immune cells, inhibit T cell, mast cells, and eosinophil cells which are involved in the inflammatory cascade. They inhibit both early and late response of asthma. Azithromycin is a repurposed drug. It has few other effects such as anti-inflammatory and immunomodulatory effect. This is recommended in add-on therapy in GINA Step 5 guidelines. New drugs in pipeline such as bitter taste receptor agonist, TAS2R agonist. Then we have selective glucocorticoid receptor modulator. Third is selective glucocorticoid receptor agonist. Fourth is adhesion molecule blockers. Fifth is peroxisome proliferator activated receptor gamma. Sixth is potassium channel opener. 7 is calcium channel blocker. 8 is dual antagonist of thromboxane A2 and PGD2. And 9th is ANPs and related peptides such as urodilatin. So bitter taste receptor agonist. Example is chloroquine, which is also effective in asthma. It causes bronchodilation via G protein phosphatidyl inositol pathway, resulting in activation of calcium dependent potassium channel, and thus potassium is going out of the cell and thus leads to hyperpolarization, relaxation of the constricted airway, and thus bronchodilation occurs. SGRM and SEGRA. Most attention is focused on the development of novel compound favoring trans-repressing action of the glucocorticoid over trans-activating. They repress the inflammation caused by various antigens or causative agent. Okay, few examples are dagrocorat, fosdagrocorat, mapracorat. This is also the sum up of the drugs which are used in asthma treatment. or or these drugs are under investigation. Immunomodulator therapy for asthma. We have subcutaneous immunotherapy or sublingual immunotherapy. So in case of allergen immunotherapy potential biomarker, APCs causes induction of Th1 cells, thus which leads to induction of Treg cells, interleukin 10, 35 and TGF beta, which leads to suppression of Th2 cell, thus decreases interleukin 4, 5, 13. Similarly, it also suppresses the mast cell, and eosinophils. B cells induction of allergen specific IgE4, suppression of allergen specific IgE. Indication for allergen specific: if patient is not responding on pharmacotherapy, then unacceptable to adverse effects, desired avoid long-term pharmacotherapy. If allergic asthma or allergic rhinitis is coexisting in same patient. Bronchial thermoplasty is one of the non-pharmacological treatment available used in severe asthma. It delivers controlled therapeutic radiofrequency energy to the airway wall, thus heating the tissue and reducing the amount of smooth muscle present in the airway wall. This is how the controller is used. Okay. One catheter is passed and in the lung. Okay. Catheter heats wall airway, burning away inflammation and opening airway to ease breathing. This is how the person without asthma, this is the severe asthma, it is constricted. Now after treatment, this has opened a little bit. After bronchial thermoplasty, inside airway wall another tissue heals, but airway is reduced, muscle is reduced. GINA 2024. Few updates that are seen in GINA 2024 is SABA is not used alone. ICS containing treatment of control symptoms or to reduce exacerbation. Low dose ICS formoterol taken for symptom relief. In children, ICS should be taken whenever SABA is taken. This is the GINA. There are two parts, that is in track 1 and track 2. Track 1 is preferred controller reliever. So an alternate track 2 is alternative controller reliever. Okay, if symptoms are not controlled by track 1, then we use track 2. So step 1 and 2 in track 1 is same, that is as needed low dose ICS with formoterol. In step 1 ICS whenever SABA is taken. Okay, we are taking SABA whenever SABA is taken. In step 2 low dose maintenance ICS, similar to this. In step 3 low dose, which is similar. Step 4 medium dose, here we have medium high dose maintenance LABA. Few add-on therapies that are being added on step 5 is anti-IgE, IL-5 receptor, 4-alpha and anti-TSLP, similarly here also. Now other controller option with limited indication, less evidence, we have in step 1 and step 2. Similarly, low dose ICS whenever SABA is taken, or LTRA, that is leukotriene receptor antagonist, or HDM slit. Then we have on step 3 we have medium dose or HDM slit. In step 4 we have LAMA and LTRA, HDM slit switch. In 5th step we have azithromycin, which is a repurposed drug use if patient is not treated. Okay, so what is HDM slit? HDM slit is immunotherapy against house dust mite. Other therapies in DINA guidelines, we have allergen immunotherapy, influenza vaccination, bronchial thermoplasty and vitamin D supplementation. Non-pharmacological intervention, that is smoking cessation, physical activity, avoidance of medication triggering asthma, avoidance of indoor allergen, then healthy diet, weight reduction and breathing exercise. Now in treatment of asthma, we are focusing on individualized medicine more, as traditional medicine was present when we started the treatment. Then evidence-based medicine came. Then we have stratified, personalized and individualized medicine. This is a precision medicine because individual phenotype and genotype is different. So individualized medicine getting um, is evolving concept nowadays. Now we have nanoparticle based delivery system in asthma. Examples of liposomes such as budesonide and fluticasone. Then we have nanoparticles. We have salbutamol and montelukast. In exosome we have siRNA to target interleukin 4 and interleukin 13. Small RNA. Nanoparticle is 1 to 100 nanometer. Liposomes having having lipophilic and lipophobic circle. Thank you so much. These are the references. Thank you.